So I'm just preparing the live streaming, and I believe we are ready to start. Let's just start recording. Great. Okay. Hello and happy Friday, everyone. Thank you very much for joining us today. We encourage everyone to keep their video on if it's possible, as it adds to the sense of community, and it would be wonderful to see you. Welcome to the next lecture in the... Oh, what is happening? Can you hear me okay now? Yeah, okay, so I can hear some voices in the background, but I think, sorry, apologies, I think it was on my end, but you can't hear any background noise. No, okay, yeah, sorry, my apologies. Okay, brilliant. So, yeah, anyway, welcome to the next lecture in the MAHSC Inaugural Lecture Series, which celebrates the remarkable contributions of our honorary MAHSC clinical chairs. So these honorary chairs are awarded annually by the Promotions Committee of the University of Manchester's Faculty of Biology, Medicine and Health to distinguished individuals across Greater Manchester. Each honoree has made significant contributions to their clinical specialty, demonstrating excellence in research, education, and clinical practice. Today, we are pleased to welcome Professor Michelle Harvie, and from the School of, from the Division of Cancer, and she will be introduced by Professor Paul Dark as the Vice Dean for Health and Care Partnerships. In our second talk, we will welcome Professor Susmito Biswas from the Division of Evolution and Genomics Sciences, and he will be also introduced by Professor Ray O'Keefe as the head of the division. Please feel free to submit your questions in the chat box, and we will address them at the end of each talk. So we are looking forward to celebrating these achievements for both of our professors today. And I will now hand it over to Paul, please. And thank you so much.
Yasmin, thank you so much for that introduction. And my name's Paul Dark. For those of you that don't know me, I've recently been appointed the new Vice Dean in the Faculty of Biology, Medicine and Health for Health and Care Partnerships. So very much about our partnerships with the health and care sector. And I wasn't part of the committee last year, but I will be chairing future award committee for the MAHSC, the University of Manchester honorary MAHSC chairs. And as Yasmin said, it's a great pleasure to be here today to introduce you to Professor Harvie. That sounds great, Michelle. Yeah. And, you know, this is a very significant award because, as Yasmin has suggested, we're making judgments based on contributions to clinical leadership at a national and international level, and also the partnership with the University of Manchester in its key missions. So in teaching and learning, student experience, in research and innovation, and of course in social responsibility. And those are the kind of things we'll be looking for as we move forward with these decisions around chairs in the future. And Michelle, it's a great pleasure that you've been awarded this. I've not worked with you before, I don't think, but I am actually aware of your work, even though I work in a very remote area of critical care medicine. Your work has had massive impact, not only across medicine, but actually, as I'm sure we're going to hear, in lifestyle more generally globally. So Michelle is lead for diet and lifestyle research at the Prevent Breast Cancer Research Unit, which I assume is at Wythenshawe, is it,
yes,
Michelle?
That's right.
Yeah, the beautiful building as
you
go onto campus. Yeah. And I'm not going to say much about Michelle's work and contributions, but there is no doubt that she is a critically important clinical leader that has real international reach. She's got collaborations around the world her work is much appreciated. The patients that benefit from Michelle's work are, I am sure, incredibly grateful and very important as part of their care pathways as sort of adjuvant approaches outside of the key diagnostics and cancer treatments and surgical treatments. And we're going to hear about that, I'm sure. She contributes enormously for the university in terms of delivering education and particularly encouraging healthcare professionals and a broad range of healthcare professionals in taking up opportunities in research, which is really welcomed. And I think the social responsibility is great. And I'm sure you're going to mention the late Michael Mosley, but over to you, Michelle, and I'm really looking forward to this. Well done.
Thank you. Thank you very much. Right. I wasn't awarded a chair for my IT skills, so let's see what happens here. Okay. Can you see my presentation?
Yes, we can, Michelle.
Good, you can hear me. Okay. So it is a great honour, a great pleasure to be able to speak to you today as Professor Harvie, and I'm going to talk to you about, do diets really work? I remember years ago a diabetologist saying diets don't work. There's no point putting people with diabetes on diets. So maybe by the end of this, you will see that they have potential power, and it is potential because they're hard to stick to. So what I'm going to cover, oh, hang on, we're not moving forward. Oh, there we go. So I'm going to summarise my research journey, tell you a bit about our breast cancer work in prevention and after diagnosis, talk about intermittent diets and how we've used those in diabetes, and then where I'm heading next. So I was brought up in Danbury, a little village in Essex, with very supportive parents. You see at the top there. I actually went to a Sandon Comprehensive School where I managed to survive and then managed to graduate to the University of go to the University of Manchester to do a biochemistry degree. And I came in 1986 mainly because I was really into the Smiths. And sadly, they split up very soon after I arrived. So I was always a bit gutted that I never got to see them in Manchester. So I then went on to do a diploma in dietetics and became a dietitian at Manchester Royal Infirmary, which is basically next door to where I did my biochemistry degree, where I had lots of supportive people like Claire Soulsby, who is pictured here, who was one of my mentors. I was very fortunate to I saw an advert for a PhD about 4 years after I'd been a dietitian. I was always really interested in oncology. And anyway, I got this PhD, which was actually not with dietitians or nutrition people. It was with Ian Campbell, an anaesthetist, Nick Thatcher, Andy Beldam, who was a breast surgeon, and Anthony Howe, who has been a mentor and a critical friend for all my years of my career since then. I got my PhD, and then a couple of years later, Tony Howe had some research money for a year back in 2001, and I'm still here on a temporary contract, but don't tell anybody. And then I was delighted to be given the honorary chair in August. So the main focus of my work has been around, can we reduce risk of breast cancer? And this has taken a number of strands. First of all, trying to define what are the risk factors and how do they work, and then how we might help people do it. So what are the risk factors? Well, about 50 years ago, it was identified that weight was a risk factor for breast cancer. And there have been numerous publications. Yeah, it's a very consistent story, postmenopausal breast cancer. And so back in the early 2000s, I was sitting in a meeting, and Tom Sellers, who is pictured at the bottom here, was presenting data from the Iowa Women's Health Study, saying that weight was a risk factor and they could consistently see this. So I asked the question, which I thought was a bit of a stupid question, but, does weight loss reduce risk in somebody who's gained weight? Can you reverse the cancer risk of excess weight? And he said, oh, that's a really good question. We've never thought of that, which I was a bit surprised about. But anyway, we constantly then collaborated, and we got access to the data. And sure enough, we were able to show that in this cohort study, weight loss was associated with a reduction in breast cancer risk. So So that there is a link there, but it's important to understand perhaps what the mechanism might be for a number of reasons to certainly strengthen a cancer prevention message that we want to give out to the public. And if we can, and we've not achieved this yet, we were always trying to find a biomarker that might respond to weight loss, like you have cholesterol for heart disease. And that would really help us to manage, risk reduction programs. And then potentially, there might be a drug that might mimic some of the effects, which could be used for cancer prevention. So a busy slide, but basically we've done a number of mechanistic studies where I have basically run the study, got women who are at increased risk of breast cancer, who've either got overweight or obesity, to go on a diet, various dietary regimens, and agree to have a breast biopsy before and after. And those biopsy samples go off to the lab where the amazing breast biology colleagues like Rob Clark, Andy Sims, who's sadly no longer with us, will look at aspects of the gene metabolism, etc. So we've conducted a number of studies with different low-calorie diets, and these are summarised here. We've also looked at whether some of the changes in the breast might be more easily seen in proteomic and metabolomic markers. And we were able to see that certainly intermittent diets do have a different proteomic pattern to a standard daily diet, but it doesn't really mimic what's happening in the breast. And we couldn't see anything in white blood cells, which we were hoping to do, which might be a better way of measuring what's happening in the breast when people follow these diets. The most recent study was in collaboration with Sasha Howe and Emma Crosby, where we actually got women to agree to not only give a breast sample, but also an endometrial biopsy before and after a low-calorie diet. And this was run fantastically by Helen Clark, a PhD student, and she has shown that when women lose 10% of weight with this diet, they're getting reductions in the stemness of the breast cells and reduced inflammation in the endometrium, things which we think are very cancer protective. So we know that weight loss could be beneficial. We've got some ideas of what it might do in the breast, but how can we actually help people change? And I guess this is Hugh, the intermittent diet. So we'd done this Iowa analysis. We realised that weight loss might be helpful. And I remember Tony dancing around the office saying, well, that's it, we've sorted out breast cancer. At which point I sort of brought him back to reality and said, but yes, people find dieting really difficult. People find the daily diet really difficult. And at the same time, I was aware that there was quite a lot of mouse studies where they'd actually put mice on either continuous diets that were sort of moderately restricted each day, or an intermittent diet where they did 1 or 2 days of a more severe restriction and then ate normally the rest of the time. And when they did that, even though they ended up being the same weight, there were actually less cancers in the intermittent dieters. And I thought, well, that's very interesting. Maybe there's a different metabolic effect of that. And so that's where we started looking at intermittent diets to see whether they could be easier to follow than daily diets and perhaps have this greater metabolic effect. So the first study was actually done in 2006. It was funded by Breast Cancer Now, and it was a proof of principle study, really. We kept the diet really, really simple. So it was just milk and fruit and veg, and it was 650 calories 2 days a week, and then healthy eating the other 5 days a week if possible. And we compared it to a standard daily healthy eating, low-calorie diet. And this was in collaboration with obviously Tony and Mary Peggington, who was a dietitian in our unit from 2006 till very recently, with Mark Matson, who was in Baltimore, and Susan Jebb, who is a nutrition professor at Oxford. And we were able to show that the diet was certainly feasible. We had 75% of adherence to the low-calorie days over a 6-month period, which is pretty good. And it was showing beneficial effects on markers of insulin resistance. So favourable results, slightly overplayed by The Sun, who reported it. So 2-day diet cuts the big C. this was the cure for cancer, which of course it wasn't, but it was interesting. So the second study, we thought we could do better. So, milk and fruit and veg can only be followed for so long. So very aware of the ideal diet for satiety and for, helping people follow it. The second iteration of the diet was a 2-day low carb, low calorie diet. And we either had a diet that was restricted in both, or one that we just said, just follow a low carb diet. So it had plenty of protein, fruits and veg, etc. And we actually showed that the headline result from this is that the intermittent dieters are in red and blue, and they lost more body fat than the daily dieters. So this is where we were able to realize, certainly in this short-term study, that intermittent dieting was possibly easier for people to do than a daily diet. And this was the basis of the 2-day diet that we developed. And we wrote a book, myself and Professor Howe, and this was published, and all the author proceeds went to prevent breast cancer. It's still out, you can still buy it. I guess the highlights were, we went to QVC shopping channel and sold out of our books twice. And everybody is still, we published these studies in 2011, 2013. People are still very interested in these diets. And actually these, the papers I've written about intermittent fasting get the highest citation rates. So that's a way of dieting, but how can we actually encourage people to follow the dietary recommendations and even think about losing weight? Is there something about the way that we frame the advice to people? So we're always trying to get people who are at higher risk of breast cancer to follow the guidelines, because they stand to gain the biggest benefits from losing weight than someone at population risk. So they're our focus, really. And I think there is a presumption that if you tell somebody they're at increased risk, they are quite that they will go away and change their behaviour. I mean, that's quite optimistic. And so this was a review I did with David French a few years ago, where we took not just cancer risk, but we took various studies that had given people a personalised disease risk and looked at whether or not it had actually changed their behaviours. And very simply, it doesn't. So just telling somebody they're at risk doesn't necessarily make them eat healthier, smoke less, drink less, which is perhaps not surprising, because those behaviour change things are quite interesting. But I think probably people have asked the wrong question. And I was very interested in whether, if you gave someone a risk of cancer, say, whether it wouldn't change their behaviour, but it might make them more motivated to join a programme, which could then help them do it. And so we were in a very fortunate position. At that time, there was a big cohort study in Manchester called the PROCAST study, where women had just been given their risks of breast cancer. They were either told they were at lower risk than population, average risk, moderate increased, or high risk. And so we invited big groups of women from these different risk categories into a weight loss programme. And we were interested to see whether there was different uptakes, retention, etc. And you can see quite clearly the higher risk women were more likely to join the study, and they were more likely to stay in it, and therefore they lost more, they were more successful overall. So there is something about giving people risk and then offering them a programme that might be helpful. And another way to make things easier for people is, even before COVID, we were doing a lot of work with remotely delivered programmes, because people really, a lot of people really struggle with coming to the hospital, finding somewhere to park. And for a lot of things, like just talking about diet, it's not really essential. And so back in 2008, we did a study with breast cancer patients. We were able to show that a weight loss intervention that was diet and exercise delivered over the phone was as effective as coming to the clinic. And more recently, we have developed a phone and web-based programme for high-risk women who come to the family history clinic, and shown that can be run across a number of hospitals. And that's something we really want to push forward. So that's the prevention. So unfortunately, we do know a lot of women will, and some men will be diagnosed with breast cancer. So can diet really help after treatment? We're not talking about having diet and no treatment. We're talking about diet as an adjuvant to your normal treatment. And again, there's a lot of stuff on the internet and a lot of interest in whether fasting and intermittent diet, 5-2 diet around the time of chemo might actually reduce some of the side effects of chemo and help its effectiveness. Sounds too good to be true. It certainly works in the mouse model where you get this differential response. I think we think it's because the healthy cells stop proliferating when you're calorie restricted, whereas the tumour cells don't, and they are more susceptible to the effects of chemotherapy. So we tested this out in a population of women going through adjuvant treatment for breast cancer in our Breast Activity and Healthy Eating After Diagnosis 2 study. So they were randomised to either an intermittent diet or a daily diet, and we were looking at whether it stopped them gaining weight and body fat, which is a problem for these patients. We wanted to make sure they maintained their lean body mass, and we were interested to see what it did to the toxicity. So the intermittent diet was more effective for controlling their weight and body fat levels. They didn't lose lean body mass. There was no overall benefit in terms of toxicity across the whole of the 6 cycles, but a post, subgroup analysis with all the caveats that has showed that in the last 3 cycles of chemo, when they were mainly getting taxanes, we were getting less severe toxicity, with only 18% of the women on the intermittent diet getting it versus 30%. So moving more recently, we were also interested in whether the low-calorie diet and some sort of measure of weight control could actually help women who are going through treatment for metastatic breast cancer, to actually see whether it could impact on the disease process. We know that heavier women do worse. So again, it's that question of reversibility. Does that mean that if we can get them to lose a bit of weight and follow a lower calorie diet during their chemotherapy, the chemotherapy might work a bit longer? So this study was actually trying to look at whether the diet would help time to disease progression. So they're on chemo for a period of time, and the longer that goes on, obviously the better, and then they might have to switch to another treatment. So they were randomized to either the intermittent diet plus resistance exercise, because we didn't want them to lose lean body mass, or just resistance exercise. And we had recruitment was poor for this study, which is very unusual for our diet studies. We think largely because of gatekeeping in the oncology, the breast units, because people didn't want to offer a low-calorie diet to patients with advanced cancer for the kind of emotional reasons I think we all have, even though these women were overweight or obese. It was finally killed by COVID. Anyway, we recruited 68 patients, and when patients were asked, there was a good uptake, and certainly there was a lot of good feedback from the women. And so this has actually not been published yet. It's just gone off to the British Journal of Cancer. So there was good adherence to the diet, as we saw in the women who didn't have breast cancer. Again, it was around 70% of them doing their low-calorie days around the time of their chemo. They lost some weight, but there does appear to be an improvement in time to disease progression. It was 42 weeks in the intermittent dieters versus 28 weeks. And this study was designed as a phase 2 screening trial with one-sided significance. So an interesting, tantalizing signal there. So that's my cancer story, or certainly some of it. But of course, diet is as or more applicable to other conditions, particularly weight control diets. And I had a very enthusiastic dietitian called Sarah McDermott, who was she worked with us on cancer. She was very interested in diabetes. And Dr. Isa here, who's an endocrinologist at MFT, was very interested in whether the intermittent diets might help patients with diabetes. And so cue the MAHSC studies. So there are three studies I'll quickly summarize. So this is Manchester intermittent versus daily diet diabetes studies. So the first study was taking patients with type 2 diabetes, and where there is good evidence that if you put them on an 800 calorie diet for between 8-12 weeks, they lose significant amounts of weight, go into remission. But we also know that only about a quarter of patients who are offered these diets actually go for them. So again, was there another way of doing it? So we tested an intermittent diet where they did 2 low-calorie days of these formula low-calorie drinks for 28 weeks versus 8 weeks of the daily diet. It was a randomized trial, patients with overweight and obesity. At the end of 12 months, the weight losses were equal. There did appear to be slightly more remission with the continuous diet, which I think is interesting, and it may be something about the rate of weight loss that you get. MAHSC type 1 was in patients with type 1 diabetes, where weight problems are becoming increasingly a problem, and they have lead to poorer outcomes, cardiovascular outcomes, etc. There are big barriers to patients with type 1 losing weight, and there's very little research done on it because of the concerns about hypo and hyperglycemia and ketonemia. So this was a very, very small study where we had, again, patients with type 1 diabetes following either an intermittent or a continuous low energy diet. And at the end of, for 3 months, and basically they appear safe with quite a lot of monitoring, and they were reducing weight and HbA1c. And the final MAHSC study that we're just finishing up now was actually in women with obesity and gestational diabetes. So we were interested to see whether during that last trimester of pregnancy, whether the intermittent diet could actually help control blood sugar and keep them off the glucose lowering medications they often end up on, including insulin. And it's a feasibility study, a randomized trial, and we're just writing it up. But basically, it looks like in this setting, the diet's not feasible. We had a huge dropout and a very low adherence to the intermittent diet, only about 30% this time, which I think highlights the issues that it's a very challenging time physically and psychologically for these women. So my last few slides, I know I talk about we all the time, and it is a we. All this research and me doing this talk, it's a team effort. There's some fantastic people I've worked with on the breast cancer studies, the diabetes studies, and the research dietitians in the project management team down at MFT, Kath Sellers, Susie Krizak. And more recently, I've been lucky to be part of the BRC prevention and early detection theme, work with people like Emma Crosby, Andrew Renahan, and the fantastic support team we have. And statistics has been really helpful. They're obviously very shy folk because I couldn't find any pictures of any of the statisticians that we've worked with that have helped. And I've been so lucky. I'm really passionate about encouraging other dietitians to get involved in research. I've had such lucky breaks. And I've had some fantastic dietitians working with me over the years, some of who have gone on to do higher degrees and got PhDs, a couple of PhD students currently. And again, we've had some dietitians doing these BRC placements, which has been fab. And there's some key people who've really supported me through the highs and lows of all this. My partner, Mark, who's been amazing and put up with all sorts of tears after failed applications and grumps and actually kept me sane, and also done some fairly crazy things to raise money for Prevent Breast Cancer. Tony Howe, amazing, been such an energy, such a mentor. Again, he seems to have done quite a lot of fundraising for Prevent. And Prevent Breast Cancer, who are the charity who've actually funded a lot of my work. So Lester Barr, Nikki Barraclough, and Professor Cleona Kerwin, who basically encouraged me to apply for this MAHSC chair and has been a great support. Where am I going next? I know there are weight loss jabs out there, but I really feel passionately we should be doing more work about weight gain prevention. So we've got some ideas for that. We need to implement the weight control work that we've got some evidence for in high-risk clinics and women attending screening. And I certainly am continuing my links with the international fasting community. There's us at the bottom there in Istanbul this year at the conference, which was very, very interesting, very special. And, I'm very keen to keep building collaborations across the Manchester BRC and the dietary community across the UK in the UK Diet and Activity Research Collaboration. So some final thoughts. Don't be afraid to ask questions. You know, my silly question about does weight loss reduce risk ended up in a great publication and a whole stream of research. Don't work in silos, you know, just because you work in cancer, you need to learn from other disciplines. You can't see me because I'm on PowerPoint, but height is not a barrier to success. I am quite small, as you can see in this pitch here with, this is Andrew Renahan and I hosting Steve Hursting, showing my full height. And research has its highs and lows, and you need to be resilient and have a great network in and out of work. And just going back to the Smiths in 1986. So in 2006, because of our work, Andy Rourke from the Smiths actually came to the Prevent Breast Cancer Centre to donate some money for one of my research projects, because he was doing some work with Manchester versus Cancer. And it was a great afternoon, and he signed my Hatful of Hollow album. So I was totally made up. So 20 years later, that was that. So that was all I was going to say, and I'm happy to take any questions. Thank you.
Thanks so much, Michelle. I mean, you've set the bar very high for next year, I think. So I've really enjoyed your lecture.
Good, thank you.
You mentioned about sort of obesity controlling drugs, and obviously we've got a very big study starting in Health Innovation Manchester fairly soon. Are there any opportunities in that study observationally to look at in a large real world trial the longer term outcomes?
Yeah, and I've had that conversation with Martin Rutter. Yes, so you're talking about the surmount real, whatever it's, yeah. So I know we are very keen to look at certainly cancer outcomes in that, and I think there is a good opportunity. I mean, I guess in that study they're going to potentially stay on the drugs as long as they can. So there's definitely work that needs to be done around maintaining weight loss when people do come off the drugs, which they may have to do not because of the licensing but because of their tolerance. So yeah, so I have been talking to Martin Rutter about whether I can be involved in that in any way. It should be good.
Seem a good opportunity, so that's fantastic. Thank you for addressing my question. Thank you. Any others?
Can I ask one, please, Paul?
Yasmin, you've got your hand up.
Yes, please, if that's okay. So
No.
Yeah, thank you so much, Michelle. It was very, very, very inspiring, I would say, to hear about all of the changes that you made by your research. And thank you so much for sharing your fabulous journey with us. So I realized that you had a slide on your very final slide for, getting some, I would say, advice to maybe our early or junior researchers, early career researchers, which was amazing. I just wanted to ask if there were any particularly challenging experience that you had maybe in the translation of your research into the healthcare, because you already had a fabulous journey. And I know you mentioned about, it was definitely a challenge for persuading and also encouraging the patients to follow the diet. So I was just wondering if there were anything more you would like to share with us, or about any lessons maybe you got from those challenges.
And I'm not sure I've learned them. I think and this is kind of where I'm at now, I really feel like we need to implement what we've learned. We keep getting more research, and I feel like we just need, and we've had various attempts with GM cancer to kind of roll things out. And yeah, it's getting, because we've got this research, and when we're doing studies, patients come in the studies, I always make sure I'm part of the study so I've got some insight into it. But it's actually but when patients come to the Prevent Centre at the moment, they don't get offered any of these services, which I think is appalling. So there is a gap, and I feel like I've probably not done enough to bridge that gap, and that's where I'm kind of stuck. So it's the implementation of these things, I think, that we really need to be better at. You know, and obviously with the NHS as it is, everyone says, oh, we can't have any new services now, and it's yeah. And I think that the other challenge down the tracks, as Paul, you know, mentioned, is the weight loss drugs. I think some people think that, you know, I might as well retire now. That's it. We're kind of done. I don't think so. Yeah.
Thank you. Amazing. Thanks so much.
Should we just take the last question? I think Susmito has got his hand up. Over.
Thank you, Michelle. It's an amazing lecture, amazing work, and you know, actually, worldwide impact is phenomenal. A lot's been said about food constituents now, isn't and it's quite trendy to talk about ultra processed and dysregulation of weight, and also things like diet and ethnicity, and sort of global trends in diets and weight gain. Did you sort of look at any of those, or is there a plan to look at any of these things in future research around cancer, weight gain, and other aspects?
So I think the processed food, I mean, this again is you know, such a hot topic. As far as I'm aware, and I think a lot of other nutritionists have this view, I think the evidence, you know, certainly points to processed food is designed to be hyper palatable, if you like that kind of food. So it's designed to be so it does make people overeat. It's marketed really aggressively, so it does make people overeat, and particularly, as you say, in you know, globally, that is paying out. I'm not sure there's anything, and they're generally, you know, foods that are very high in fat, salt, sugar, etc. So I think I'm not sure there's something inherent about the emulsifiers and, you know, the fact that it's in a plastic bag. I think it's the whole and the hyperpalatability, the balance of fat and sugar, etc. So you know, and we've always advised people to, I guess our advice has always been, you know, not to have those, but to have the healthier food. I mean, basically, if you're having one of those diets, you're not having a healthy diet. So I think it's, yeah, we've kind of been doing it the other way around, is encouraging people what to have rather than demonizing a certain food. And I do have a big concern, actually, that there's a lot of foods that are being demonized in that whole process thing. The definitions are quite odd, actually. There's a lot of foods that people rely on, especially people with not that much income. And I feel like we could actually really, you know, make things worse potentially. I mean, certainly the food companies need to be taken to task, and that's a bigger issue. But I think probably not beyond the weight loss. I don't think there's probably anything inherent in those foods that are linking to cancer risk, but there's certainly things we should be keeping an eye on. Yeah, good question. Thank you.
Thanks, Michelle, and congratulations. It was a wonderful talk. And I'll go back to Yasmin now for the next part of today's celebration.
Thank you so much, Paul. So I'm handing it over to Ray now for the second lecture, please. Thank you.
Okay, great. Thank you very much, Yasmin and Paul and Michelle. That was really inspiring talk. Thank you. So my name is Ray O'Keefe. I'm the head of division of evolution, infection and genomics in the School of Biological Sciences. And it's my pleasure to introduce Professor Susmito Biswas. So Susmito is a consultant ophthalmologist with a specialist interest in pediatric ophthalmology, and he's based at the Manchester Royal Eye Hospital. He's built an international reputation for corneal disease management in children and retinopathy of prematurity, or ROP, management. He's grown a large referral service for complex high-risk pediatric corneal surgery, receiving national and overseas referrals. As clinical lead for the pediatric ophthalmology and MFT since 2016, he's been at the forefront of pioneering ocular gene therapies. He's held many important national and international roles, which are really too many to list here, but one important role is he's currently chair of the Royal College of Ophthalmologists Pediatric Subcommittee. This is a UK-wide subcommittee of the Royal College Professional Standards Committee, and it contributes to national policy statements and guidance documents pertaining to pediatric ophthalmology. Over the years, we've been very lucky that Susmito's had very strong links to the researchers in our division, where he's had some major roles in some really high impact publications. For example, he's been involved in some really important gene identifications for identifying a major group of corneal endothelial disorders. And his research has really pushed forward the use of next generation sequencing for more rapid diagnosis of congenital cataract. Susmito's, congratulations on your award of MAHSC Honorary Clinical Chair. We look forward to your continued interaction with us in the division, the researchers in the division. We've got some really good interactions with you, which we really want to continue. And we really look forward to hearing about your journey to this point now.
Thank you very much. So I'm just going to share my slides and go onto presentation mode. Right. I think thank you, Ray, for that very kind introduction. It's an absolute major honor to be given this opportunity to give this lecture and being awarded this chair. Somewhat unexpected, but very welcome. So as is traditional with these inaugural lectures, I'm just going to give you a bit about my background and some of the clinical work I do, and some of the future projects. So a little bit about my background. So this is my family on the right there. My father and mother both came from West Bengal in India. My father from Assam, my mother from just outside Calcutta. They came to the UK in the late 50s, early 60s. That's myself and my sister there. I was born in Liverpool, so I am actually from the north. But I did, because my father's job took him globe-trotting around the world, I didn't spend very long in Liverpool. I ended up in Brazil for a few years and then came back down to live in London. Note the guitar, that will come up later. In London, I was educated in Hertfordshire. I didn't enjoy school very much, but I was quite fortunate to be in a class in my sixth form of almost exclusive medics. There were about 16 of us, and that really helped spur us on to success. And most of us, in fact, I think about 15 out of 16 got into medical school from my class. So that was impressive. So I did go to St. Bartholomew's Hospital Medical School, and here I had a chance to do an intercalated BSc in experimental pharmacology, and I got my first publication looking at nerve conduction in mice that were fed a high galactose diet. I have to say I read through this publication. I'm quite amazed that I did that because I barely understood any of it at this time. But the other thing that I found during medical school was my interest in ophthalmology, and I did enter into a prize for ophthalmology. Part of the reason was because of my interest, but the other part of the reason was because it was actually the most lucrative prize at the college. It was worth £500, the proceeds of which I went ahead and bought a guitar with. So going back to that guitar reference. So while I was a house officer, I was deciding how to proceed with my planned career in ophthalmology. And it was my sister actually who pointed out a BMJ advert for a job in Manchester, which was actually probably one of the best jobs going around at the time, which was a 2-year rotation in ophthalmology, starting off with a 6-month lectureship in anatomy at the university. And that was devised by David MacLeod, who you can see in the image there. He was the head of the department at the time, and I thought that I'd go up and meet him. And he met me in his office, cigar in hand, to explain all the great things about Manchester. So I did apply for the post, and unfortunately, I managed to get that position. And at the time, just to look back on at the time at the eye hospital in Manchester, there were just 12 consultant ophthalmologists at the time, and I was fortunate enough to lead the department in 2012 to 2018 as the clinical head of division. And by the time I left, we were something like 44 consultants. So there's a massive expansion in that short period of time from when I was appointed in the early 90s. Now, one of the first people that I had a clinical attachment with was Alan Ridgway, who sadly died a few years ago. But Alan Ridgway was a fierce consultant at the time, and he did put the fear of God into me. But he also made me very interested in corneal disease. And then down here, many of you will recognize Chris Lloyd. So Chris Lloyd was the first consultant that I worked with as a registrar at the eye hospital, and he instilled in me the interest in pediatric ophthalmology. So at the end of my senior house officer post, I managed to secure my fellowship of the Royal College of Ophthalmology. So you had to get your Part 3 before you went on to higher surgical training. And so following this, I mentioned to Professor MacLeod at the time that I'd just passed, and he said, "Oh, that's perfect timing because we're advertising for Calman trainees in the next week." So again, good timing. Managed to get that. Now in a position of settlement, I decided that I could settle down with my girlfriend at the time, Grania, who's now my wife, married for 27 years. So during my time as a registrar, certainly my time with Chris, I interacted with Graham Black. Graham was brought into the eye hospital to actually increase the linkage between the eye hospital and the academic department of genetics, which he's done immensely successfully. And I spoke to Graham at the time saying that I need to know more about genetics, and do you have any ideas for some research? And he did. He had several families from the northwest of England that had this unusual early onset corneal dystrophy. And he said, "Well, why didn't you have a look at that?" So I said, "All right, that sounds interesting." So I went off to see all these families to genotype and phenotype them in the northwest. And at the same time, Graham got in contact with the fellow at the top of the slide, Francis Munier. Francis is a world internationally renowned ophthalmologist who works at Lausanne in Switzerland. And he was also interested in this. So Graham said to me, "Well, why don't you go over to Lausanne?" And I said, "Well, okay, I'll go over for a few months." And I worked with the chap in the middle, Pascal Cousin, in the lab run that was directed by Daniel Chaudray at the bottom of the bottom right. And during that time, we did a whole genome-wide search of this family, family that you can see the family tree on. And it was painstaking work at the time. We didn't have any next-generation sequencing, so it was quite rigorous chromosome by chromosome, marker by marker sequencing that was done in the family. And at the end of this time, we managed to identify a small section on chromosome 1 where there might be a gene. So looking at this, we found an interesting gene called COL8A2, which coded for the alpha-2 chain of type 8 collagen, that was expressed in the cornea. And that was the only thing that really sort of lit up in that area. And so we sequenced that gene, and lo and behold, we did find a variant. Now, this was the first ever gene found to be responsible for a group of disorders that affect the corneal endothelium. Up till that time, this common disorder of endothelial dystrophy wasn't well characterized from a genetic point of view. Since then, various other genes have been found, and in fact, COL8A2 probably only represents a relatively small one, but it was a breakthrough nonetheless. I reached a bit of a crossroads at the time in terms of where I go to next, and I was aware that a job in Manchester was coming up for a consultant ophthalmologist, and it would be a great opportunity to work alongside Chris Lloyd. So I decided at this point that I would do a fellowship down in London in paediatric ophthalmology, where I worked with Wagi Atalamandos in King's College, where he was leading the retinopathy prematurity service, and therefore sort of aroused my interest in ROP. And then also at Great Ormond Street with Ken Nischel, he was internationally renowned for his work in corneal transplantation in children and in anterior segment disease in infants and children. And he certainly stimulated my interest in this aspect of ophthalmology. So I'll talk about that for the next part of the talk. So anterior segment developmental abnormalities are a combination of disorders that affect the front of the eye. That can result in corneal opacities, glaucoma, cataracts, and various developmental changes, which can lead to severe visual loss and are extremely challenging to manage. And these are just some examples here of what these conditions can look like. Just to briefly go over anterior segment development, this occurs in the tectal plate of the forebrain, starting around 7th week of gestation, with the development of the optic vesicle. It's a very synchronous and well conducted series of events that involve all layers of the eye: the surface ectoderm, periocular mesenchyme, neural crest, and neuroectoderm derived tissues. And we can see that this optic vesicle makes contact with the surface ectoderm, and through a series of inductive events under the control of various signaling molecules will direct some of these cells in contact with it to develop into the developing lens. That's the lens placode, which shows high levels of expression of PAC6, and PAC6 is a master controller of ocular development. This then subsequently goes on to form the optic pit, which then invaginates into a cup forming from the optic vesicle under the control of various other transcription factors that I've highlighted here. And then other signaling molecules in the lens are critical to the further development of the anterior segment of the eye. PAC6 is also directing influx of neural crest cells and mesenchymal cells into the front of the eye, and again through interaction with other transcription factors, PITX2 and FOXC1. These control the organization and differentiation of cells that form the cornea. The first wave of cells forming the corneal endothelium, second wave forming the corneal stroma, and the final wave, the third wave, forming the trabecular meshwork and angle structures, which are involved in glaucoma and the drainage of fluid from the eye, as well as the formation of the iris. Formation of the iris continues with ongoing expression of PAC6, and with the in conjunction with other signaling molecules and transcription factors, goes on to develop the iris stroma and angle structures to full maturity. The reason why I mention all these things is that when we see a child with anterior segment developmental abnormality, there's a good chance that this could be just a random change, just a somatic problem, but there's also a possibility that this could be a systemic genetic germline variant in a critical gene involved in the development of the anterior segment of the eye. And so in our cohort of patients that we see in Manchester, looking at the various genetic abnormalities that give rise to these anterior segment dysgenesis phenotypes, we can see a whole array of developmental genes that are involved. And one common one is, as you can see there, PAC6. Not surprisingly, it's involved in it's a master regulator of gene of ocular development. So PAX6 is typically associated with this condition called aniridia, which, as the name implies, involves missing iris. In fact, the iris is not missing, but it's extremely underdeveloped. So there's a little stump of iris here. But in addition to that, you can get corneal problems, cataract, and whole eye problems, including underdevelopment of the fovea, the central part of the retina. There are two key issues with aniridia. One is that it may be syndromic. One condition that we are aware of is this contiguous gene deletion syndrome called WAGR, which involves a deletion of genes, including the WT1 gene, PAX6, and BDNF, which give rise to this array of problems. And so, in order to, whenever we see a family with a new case of aniridia, we would undergo some investigations to try and rule this out, including CGH arrays, and until we got a result, we would submit them for renal surveillance. But most PAX6 mutations giving rise to the typical aniridia case are due to gene deletions or inversions. But we have a number of PAX6 missense mutations which give rise to variants of aniridia. And looking at this group, they're quite interesting in that they have a whole array of different abnormalities, including the full spectrum of aniridia, but some may just present with nystagmus, Peters anomaly, which is a congenital central corneal opacity, iris abnormalities, including abnormally positioned pupils, iris hyperplasia, colobomas, small eyes, glaucoma, and corneal inflammation of keratitis. These are some examples in a family that we have with a missense mutation, with the father having iris hyperplasia, foveal hyperplasia, as well as nystagmus and keratitis, and then his daughter a slightly variant expression with Peters anomaly, that's central corneal opacity, as well as microphthalmia and iris hyperplasia. So we can see these missense mutations can result in quite variable phenotypes even within families. But also looking at non-PAX6 related developmental genes, we can see that many of these will present with different ocular phenotypes. Some will present with glaucoma, Axenfeld-Rieger anomaly, cataracts, lens dislocations, iris abnormalities, Peters anomaly, corneal ectasias, and small corneas and small pupils. And just to give you again a flavor of what we see, so CYP1B1 is one of the common recessive disorders that give rise to congenital glaucoma. So these are children will present with enlarged globes. Here you can see a sort of stretch mark in the cornea due to enlargement. But we can also see iris abnormalities, subtle iris changes, and chorectopia, as well as angle abnormalities. And this is the sort of typical abnormal drainage angle that we can see in children with CYP1B1 disorders, with this scalloped margin instead of a straight edge on the border. And in our cohort, we have a few cases of more severe anterior segment developmental abnormalities with central corneal opacities like Peters anomaly. And we have other non-PAX6 related anterior segment developmental genes like PITX2 and FOXC1, which I mentioned earlier, which are important in the development of the front of the eye. And this gives rise to various changes in the front of the eye, like posterior embrytoxin, this line here that you can see a little bit better on this gonioscopy image with iris processes attached to the cornea. Iris hypoplasia, which can look a bit like aniridia, but is not, as well as other iris and pupillary abnormalities, so multiple pupils as well as dislocated pupil positioning and glaucoma. So one aspect is to try and define what causes the anterior segment developmental abnormality, but the other aspect that we have to deal with is how we manage it subsequently. And so the management of these corneal opacities is quite a complex affair involving imaging, investigations, electrodiagnostics, and then ongoing surgical management. So the imaging we would do includes ultrasound by microscopy. So this ultrasound image of the front of the eye demonstrates the developmental abnormality very nicely. Here you have an abnormal thickened cornea with opacity, and this is the lens, and you can see the lens is actually attached and fused to the front of the eye, and this harkens back to the developmental changes that can arise from variants in genes that are involved in that normal separation of the lens vesicle from the overlying cornea. So that demonstrates it quite nicely. And this gives rise to these corneal opacities. We want to know whether the eye has any potential for vision. We'll do ultrasound scans of the eye to see whether there's any abnormality at the back of the eye. We've got some other imaging devices to look at the cornea in detail. This is an OCT scan. The optical coherence tomography scan here shows attachment of the iris still to the front of the cornea, and this is the UBM being carried out in practice. Now, some of these eyes are amenable to surgery, and part of my role here in Manchester, one of the things that we lead in is corneal transplantation in children. This is an extremely challenging surgery, not least because there's a high rate of failure in these cases. This is a technique which we use in Manchester. The eyes tend to want to expel its contents when we take the cornea off. So putting a new cornea on top of the old cornea before removing the old cornea is a safe way of carrying out this procedure, and that helps avoid any disastrous loss of the eye during surgery. So we've become a referral centre nationally. I receive referrals from all over the north of England and Scotland and Ireland, as well as abroad. Looking at our results, we've done 41 cases of transplantations. Median age at time of surgery is 7.5 months. We look at all those cases where amblyopia is the main feature of this, and this is below the age of 8, and a median follow-up of 22 months. And you can see here from our results that there is quite a modest failure rate in terms of graft clarity, with 50% failing by around 250 weeks or so. However, failure doesn't necessarily mean that the child hasn't benefited from it. And when we look at the visual outcomes of these cases, what we're trying to achieve is some form of developmental vision. And really, those cases where they're getting vision in this category are the ones that are really benefiting from surgery, whereas those that just have light perception or no light perception really perhaps haven't benefited from surgery. But as you can see, the majority are getting some benefit in terms of developmental vision. So in terms of pushing this forward, I was given the honour of delivering the Duke Elder eponymous lecture at the college last year, as well as delivering the eponymous lecture in Ukraine in the middle of their war, which I did over Teams. And the challenge of it, I think, is worth it, because when you see this is a family, this little baby I did the transplant of, and although the challenge is there, you can see quite clearly that this has a massive impact on the family as well as the child. So in terms of future projects, I'll just briefly go over things. One area, again, that I mentioned that I was interested in is retinopathy of prematurity. We have, since the early 2000s, really led the way in terms of nurse-led imaging for ROP in the UK. And this has now reached the stage where we're really trying to develop this paradigm for retinopathy of prematurity screening across the whole of the northwest of England. That's 22 units that are now looking to adopt this model of nurse-led screening. And that's Julie Flanagan and Annie Mallon there. They won a Health Service Journal award for the service recently this year. And Julie has developed this RAP nurse training package. Another area that we're developing in Manchester is the nephropathic cystinosis NDT service. So Manchester is a hub in the UK, one of three, Manchester, Birmingham, and Guy's and St Thomas's in London, working with Amrit Kaur, Fiona Carley, Muir Morton, and Alicia Gillette. We are now one of three hubs that look after this metabolic multi-system disease that affects the eyes, the kidneys, and the rest of the body. And there's a lot of research that we now can do to understand this rare disease more thoroughly going forward with our fellow hub centres. And this is the role of the hub is to act as a highly specialised, coordinated, multi-specialty centre that can feed back to the other units local to the patients, as well as undertake genetic testing and monitoring. So finally, I'd just like to thank all my colleagues who work alongside me. Jane Ashworth, who actually got the SHO job at the same time as me, way back in the early 90s at the same interview. Barmi, Shenoy, Rahana Sadia, Vinod Sharma, and Panos Sigouniotis, who's going to take our genetics further forward. Fiona Carley, who has been very helpful with regard to advising around corneal transplantations in these complex cases. And Cecilia Pennerty, who's our current medical director, who's helped us with managing the glaucoma in some of these complex corneal transplant cases. And finally, I'd like to thank my family, keep me very much grounded. My mother, who's just been fighting cancer this year, she's just come out of chemotherapy and is doing well. My sister, who I mentioned earlier, she's actually a professor of radiology at Imperial College in London, and she's been very instrumental in my career development. And then my father, who sadly died last year, but at the inauguration of my sister's chair in London, said, "When are you going to get yours?" And so he just missed out on for a few months, unfortunately. And of course, my family, my kids there, who just like keep me in my place, which is all important. So thank you very much for listening.
Great, fabulous, really great talk, Susmito. Are there any questions? I think I can start out with one, please. So these very young children that you see with these eye disorders, does it affect both eyes?
So it can be bilateral. No, those are the cases where really I'm thinking about how to rehabilitate their vision. With the unilateral cases, I do often get these referrals for unilateral severe anterior segment disorders. But if the other eye is normal, then actually just because of the sheer complexity of managing these cases and the high failure rate, I try and put the parents off. I have done one or two, but the reality is that it's life-changing for the family. Because the surgery is so complex, because the high rate of failure depends on really fastidious monitoring. I do tell them that you will have to come to hospital anything up to 50 times in the first year following your transplant. And I've had families move to Manchester as a result, because of this. It's a huge commitment. It sometimes means they can't carry on with their jobs, or someone has to give up work. I can't emphasize enough how much of a commitment this is to the family, not just to us, but it's the family in the main.
So it's really, really important decisions and really impactful decisions. And is it you who sort of counsels them with those decisions, or do you have a team who helps out with that?
Well, I mean, I acknowledge my team and all my colleagues who work alongside me. And one of the great things about the team I have is that we share patients. So, you know, when we see each other's patients, we know exactly what the other person's thinking. We talk about each case with each other. So we do share the burden somewhat in terms of counselling. But in terms of, you know, giving the sort of nitty-gritty of the surgery and the follow-up, you know, I tend to talk to the families myself about that.
Okay. See, Suzanne's got her hand up.
Thank you. That was really, really interesting for me. My clinical role is an advanced nurse, neonatal nurse practitioner. And now I work at the University of Salford teaching student midwives how to actually detect congenital cataracts or indeed any sort of eye issues, really. My question is, so in terms of this procedure, how long would you normally expect to, as you said, they were roughly 7 months old when they would have this done. How long do they tend to be an inpatient for, and what sort of pain management is required for them?
Yeah, so it's a good question. So a lot of the role of the midwives and pediatricians at the newborn examination, they're looking for eye abnormalities, but specifically looking for cataracts, congenital cataracts. And for congenital cataracts, we have a very strict pathway that these patients need to be referred to us within 2 weeks, and we try and operate on these patients within 6 weeks, and that's because of the critical period of ocular development. And what we're really aiming for with cataracts is we're trying to get remove that opacity and resume normal visual development, with the aim to get them to as good vision as possible, 6/6, you know, or 20/20 vision. However, with congenital corneal opacities, the surgery is more complex. It's has got a high failure rate. It's technically quite challenging in very small eyes. And so I don't tend to comply with that 6-week rule, simply because the outcomes are better if you delay surgery a little bit more. So ideally, I'll operate around 3 to 4 months of age. Pain management, it's not too bad because it's mostly the ocular surface, but they will require to be kept in hospital overnight. We may keep them in a few days to control pressure in their eyes. That's the main problem immediately post-operatively. But like I said, in the first few weeks, we're seeing them often twice a week, and then we gradually spread out the appointments. So, you know, it is quite a disruptive process for the families. But I think that delaying surgery a little bit does help to give you somewhat better outcomes, simply because of the technical ease in a slightly older baby rather than a very young one.
Thank you.
Okay, great. Are there any other questions? Look like it. So yeah, I guess I'll hand back to Yasmin. Thank you so much, Susmito. And again, congratulations on getting your professorship, and look forward to some really exciting collaborations in the future with you.
Yeah, thank you so much, Susmito, and also thank you so much, Ray. So I believe this brings our event to a close. So thank you so much, everyone, once more for joining us today, and congratulations, huge congratulations again to both of our professors, Professor Harvie and Professor Biswas. And thank you both for sharing your fascinating journey with us and your fascinating research with us today. Please keep an eye out for the next lecture in our inaugural lecture series taking place in December, 13th of December, where we will celebrate one of our recent MAHSC honorary clinical chairs, Professor Eccles. Wishing you all a wonderful weekend, and thank you so much for joining us again.
Thank you, Yasmin.
Thank you. Bye.